Okay. And I'm Michelle Rickerby. I'm here in Rhode Island, connected with Brown. So great to see everybody. A lot of people who had come last time are here and some new folks, which is awesome. And I think everyone knows this is still really an evolving format. And we're really looking to everybody to shape it together. It just with everybody here in the room, I mean, it's incredible just the experience and breadth of settings and everything that we have. So we have opportunities to have really amazing discussions, I think. Last time, Nora and group had shared a really interesting case that led to a lot of great discussion. And if they have another one, that's great. If other people have cases they would like to share, that's great. Or other topics. Andy had brought up a topic that was interesting and may apply to some of what we might talk about with a case. Andy, do you want to toss out there just the topic you brought up, just so folks know and are thinking about it?
Yeah, it's so I was thinking there's also the question of how we introduce family therapy as an intervention. And I want to say convince, though I don't think that's the right word, but invite families to participate. It's sort of like getting them into the room. I think we talk a lot about once you have a family and you're working with them, what you do, but that transition from many of our settings are not, they don't start with family therapy. So how do we describe that? And I think the other piece that kind of goes along with that is the cultural component. How do we inquire about where this would fit into their family's culture and identity, whether, talking as a family together is already happening, or, sort of where hierarchy exists or not, those sorts of things to think about how we might set up family therapy for a particular family, or whether it's a modality that makes sense or is welcome. Like, there's a lot there, but I think almost like an informed, like general informed consent and culturally informed consent.
It's a great topic, and I find it's one that in the training clinic and cases, a lot of times the trainees are struggling with as well, sort of how to talk about it. And of course, they're in situations often where they don't even do their own scheduling, right? So people just show up, right? Which is one challenge that can happen because you don't really have control over it sometimes.
I think that speaks to Betsy's point too, that like, if if you're a trainee and you only have a limited number of spots for family or even just therapy cases in general, to like really advocate helping the trainees protect some of those spots for people who are likely cases that are a little bit simpler and likely to respond to treatment. Because if they have a good experience with somebody getting better and responding to the treatment in the ways that we hope, then they're going to be more able to kind of sell family therapy next time, maybe to a case that's going to be harder,
Yeah, it definitely speaks to having them have a range of experiences, I think, right?
Yeah.
Like a lot of times trainees will like following cases from inpatient into outpatient, et cetera, right? That may be more complicated, which is great. But then if they get overloaded with that can be hard. So
or
what
they might
is
just be drawn to help the people who are the most, in the most distress or the most, have the most symptoms, and they might just be more empathically drawn to that. But it's okay for us to make some decisions about like, sort of rationing treatment, if it not treatment in general, but maybe just their particular availability, rationing that to cases that are gonna have, a likelihood of response to the treatment.
What are folks thinking? This is a great topic we can get into, what Chrissy's bringing up, and Andy, we can take some time on this, then maybe share another case.
I think it depends a lot on the setting, so that in our clinic, being an OMH clinic, we get a high percentage of cases in which there's multiple problems, psychiatric and otherwise, in the family. But in consultation liaison, it's a broader population. And so we often will find cases from there that are really good teaching cases. And they do need the help, but they're not the most complicated. And I am afraid that this year in particular, my trainees really have gotten disappointed about how little they were able to accomplish while doing good work, because there was just so many obstacles in the ability of the adults in the scene to be able to participate. So I think that's a, you know, how do the cases get into our system is one question, and then how do they get selected? In our case, our trainees tend to find their own cases. I mean, first of all, we have this, you have to go down the list, you know, of the waiting list. That's an OMH requirement. So there has to be an absolute rule about bumping somebody up, and often they're the most acute cases, and the most acute cases are often the most multiple problems. So that's a systemic problem for us. And I don't know what, you know, what the situation is for other people, but I do think it's something that we need to address and help people figure that out.
Yeah, I mean, when I was teaching, usually oftentimes that would be the case at a given clinic, but the residents would still be able to help decide, like with their supervisors, which patients got just straight up med management, versus which patients got the sort of coveted therapy spots. And and a lot of times the coveted therapy spots, even though it's more hours per family, wouldn't be the sickest people. They'd be the people who have a, you know, who might be able to utilize therapy better. So
that's a good strategy, to have the supervisor involved in the selection, the case selection.
well, that's what I would do when I was teaching at UCD, is trying to brainstorm with people, like who's in your caseload overall, and you know, how they could think of who to invite to therapy. Yeah.
We have a system here where I know everywhere's different with how they divide supervision, where there's like a core supervisor who's someone who for sure has the overview of like the whole caseload. And then people might have other supervisors as well that they dig into cases in more depth. So that can be in that role, Chrissy, to kind of advocate for balance, right? If they're getting referred
if you're
to.
yeah, if you're the therapy supervisor too, and you're seeing that pattern, maybe like going to that core supervisor and asking for their help too.
Yeah. Well, what we're working towards in our clinic is to incorporate family assessment into the psychiatric assessment. So when our clinicians in the clinic, who are not psychiatrists, request a psychiatric evaluation for medication, we encourage our trainees to pick at least some to do a complete family assessment, you know, using the family relational process thing that I do, or some other approach. And then they can select from there. But they usually feel that if they do the assessment and they understand the problem, that they ought to take it on. But I think that we might need to help them, as Chrissy says, you know, triage.
Yeah, along those lines, I always encourage the trainees when they're going year to year, for the new people coming in to do their own new evaluation of the child and family, and then decide with their supervisor what they're going to recommend, what's needed. I've pushed hard against back cases getting transferred with this is quote individual therapy or this is that, because I really think that's part of the learning process. When someone's coming in new, they need to do their own assessment, right, and come to some understanding of it.
That's a lovely opportunity, because they do get cases whether they like it or not. And
yeah.
At Columbia, we tried to pilot something that didn't really pan out, but this conversation is making me rethink we should give it another whirl, of with the idea being to move the wait list along, to invite families to join family work, even on a temporary basis, while they're awaiting an individual therapist or a medication management provider. And then, you know, potentially work on some of the problems that then maybe won't require an individual therapist or medication down the road. So we were trying to kind of think creatively in terms of just the need and getting people in. And I think we tried to pilot it with a few cases at special needs, but it kind of didn't pan out. I think there was a lot of hesitation from the families, to Andy's point, just kind of wary of what is this whole family therapy thing anyway. No, we'll just wait. We'll wait until, you know, we're assigned to the individual therapist. So still
that speaks to that speaks importantly to Andy's question about how do you frame it to families? And the way we have found works best is to say, we need your help to figure out what's going on with your kid. And the best way we can get that is to see the family thinking together and along with us, not, in general, to see how you work together. I wonder if in your case, I love that idea. It might be to offer them the opportunity to manage the situation until they can get seen for individual evaluation, and that we avoid the term family therapy because it automatically implies there's something wrong with the family. So we have this little bucket and we put a nickel in every time somebody slips, and we haven't gone out for too many beers for a while now, so that's a good sign. But families might respond to the idea that they come to work together, and then if they say, well, could just the mom come, then you'd have to say, well, what we found is that it's most effective if we have the people who are most involved with the child who live in the household, including even kids, siblings, because sometimes they have good ideas. So you'd be sort of light about it, but sort of believe in it yourself. And then that can sometimes work. Sometimes.
On similar lines, it's interesting, over the years, I've evolved into, because I actually do now in private practice get a lot of referrals specifically for family therapy, right? There are often families where there's many providers involved for years, right? There's sometimes cases where there's long estrangements, etc. So I've gotten better in general, in those cases, and in general, saying up front, like, yes, family therapy may be part of what we're doing, but that doesn't mean everyone's in the room all together. And I'm going to work with you as we decide like what order to go and how to do it. Because some of these cases, again, people literally can't be in the room without killing each other to start. And so it's kind of like a map to get into it, which is very interesting. I've thought that that topic of, and I've had so many of these cases, again, where people are in treatment for a long time and no one's kind of often talking to the parents of the kids or things like that. They're not bridging. I thought it would be a great thing to do like a clinical case conference on at some point, because I think there's a lot to learn in both directions, both just the family's experience and when you go in and you look at the big picture, like what would have been helpful to think about earlier, right? In terms of just involving the family members in the treatment, even if it's not family therapy per se.
Mm-hmm.
I love, Andy, that you brought up cultural issues as well. And I think also the other thing that's very important is access to care issues, right? And we're dealing with so many families who literally can't get to the appointment, or a parent's working and all of those things. And I think we really need to be better at addressing that. I think working online has led to some creative solutions that have made it both harder and easier in some ways.
Yeah, I really appreciate that. I think I understand the perspective of serving families who can show up in the formats we offer. I would hope that that never happens without also considering how can we adapt the formats to help the families that aren't able to show up. And there's a lot of factors in that. Sometimes, for a family to show up, they have to feel welcome and safe, and also motivated, and that it's a priority. Like there's a mix of things, some of which we can't control, but as we're allowing some families to take advantage, those tend to be the ones that have better access to other things like transportation and flexibility and English language, that make them families that can show up and participate and sort of get something out of the treatment. So we do want to use our resources and not just let them sit empty, but we also need to modify our resources to address what we're missing together.
I'm wondering oh, go ahead, Tom.
A couple of thoughts. I agree with Betsy. I stopped doing family therapy about 30 years ago. I do therapy with the help of families. And when people say, who should come? I say, anybody who's part of the problem or who could be part of the solution. Please bring as many people as you feel meet either of those categories. And I also believe that it's better to start with a big group and get smaller rather than start with a small group. This addresses Michelle's point about having 5 therapists seeing 5 different family members. All of those therapists are at a disadvantage if they haven't had all the people in the room at the same time to begin with.
Yeah, it really can make problems worse. I honestly believe if people aren't getting the big picture. I'm wondering if anyone does have a case, including the one Elena, I think, mentioned that you guys might want to talk about that I'm sure may have some themes related to this. Would people like to jump into a case?
I just want to say we certainly don't want to hog the floor. I'm aware, our crew shared one last time, so please, if anyone else has one, we certainly want to share the space.
We love that you're all here together. Like, that's
Yes.
awesome. Like, go for it.
The team.
Yeah.
So I can share about the case. Let's see. So my patient is my patient is a 17-year-old Black female who's a senior in high school. And in family therapy, she's being seen with her mother and her older brother, who is 20 years old, in family therapy. Nora's actually the mom psychiatrist, and the brother used to be seen by an individual therapist at our clinic as well. This is actually a family that has been seen at our clinic for, I don't know, literally ever. But I've been meeting with my particular patient for about 3 years now. And she was transferred to me. And actually, Elena used to work with my patient in individual therapy. So we're all kind of connected to this family in some way. And I actually think this is a great case to bring up because there was actually a crisis recently, actually last week, that might be helpful to talk through. So to give you all a little bit more of some background. So those are the 3 family members, the daughter, the mom, and the brother. They all live together in Brooklyn in an apartment. The daughter, which is my patient, she's extremely high functioning. She's set to be the valedictorian at her school. She's going to attend college in the fall, got a full ride. She's working, doing a ton of extracurriculars. The son, he has had selective mutism since we've known him. So that's made family therapy quite, I don't know, we've had to be creative in family therapy just because he won't speak to the family therapist. So what he does is write in the chat instead to communicate. And
You're talking about the 20-year-old?
correct.
Okay.
So it's my understanding that he speaks to other people, but because he has been at our clinic for so long, I think the clinicians at our clinic are like tainted. So they're people that he won't feel comfortable speaking with and using his voice with, I mean. So yeah, that's kind of like created a situation where we have to be a little bit creative to have him communicate with the family therapist. The mom, I don't know too much about her own personal history. What I do know is that she had, there was domestic violence and extensive complex trauma with the children's father, although I don't know the details of that. So in family therapy, what the family therapist has kind of been working on is a few things, right? Kind of helping the family communicate better. Because what happens a lot of times is that the family doesn't like really speak with each other when there's conflict. So what will happen is that mom or kids will text each other, even though they're like under the same roof. Like instead of kind of having conversations with each other, they'll text each other when they're upset about whatever is going on inside the house. So that's one thing. I do know that mom has like an extensive history of depression where she used to lock herself in her room and self-isolate. And particularly my patient, who's the youngest, she would take on more of a parental role, trying to pull mom out of the room. I know even with her brother, who's older, she would kind of like be his voice at school. So kind of like go up on stage to pick up his award, right? Do things like that to kind of be his voice. So she's really taken on a parental role, which has continued. So right now, mom and brother, one of the biggest issues is that inside the household is that the brother really hasn't launched. He primarily sits in his room right now, playing video games all day, and mom has really been pushing him to get a job. He has been employed 2 times, but shortly lost those jobs. One time because he just like didn't show up during a snow day, and then the other time he had like punched a wall while playing video games, and he needed his hand to work, so he was let go. And he's really struggled to just like find employment or find the motivation to find employment. So that caused a lot of conflicts within the household. Mom also is unemployed. She has a number of medical issues going on for her, which contribute to like her ability to find work outside the home. Although that's kind of been something that's been worked on as well, because what's been happening is that my patient, who's now going off to college, has been, you know, the only one working. And so she helps provide for the family. She helps buy like groceries and dinner and pay for some bills. And I think, yeah, that's just created like a very complex family dynamic. And she's leaving. And so we're trying to kind of more recently help the family launch in terms of like the brother find employment and mom find ways that she can also earn money, whether it be like she's a seamstress, so maybe doing something like that. So those are like some ways that we've kind of been helping the family launch, but more concerning is that we've been really concerned that there's going to be something that happens within the family system that keeps my patient from going to college. So we've been kind of concerned that something's going to happen where my patient's going to feel like I can't go to college. I need to stay home and take care of everyone.
You mentioned there was a crisis this week.
Yeah.
Was that something different or?
Yeah, so nope.
Oh.
So that's where I'm going.
Okay.
So this past last week, we learned that there ended up being a physical altercation between the mom and brother. So what triggered this was basically there was a miscommunication about something about getting money out of the ATM. The son cursed at the mom on the phone. Mom was, of course, very upset when the son got home. They got into verbal altercation, continued to escalate, and per the mom, like the son made a motion with his fist, and she felt really triggered by that, and so she punched him in the face. Apparently they punched each other back and forth a few times. My patient walked into the son like picking up the mother and slamming her on the floor. And then my patient was the one to break up the altercation. Mom then called 911 to get the son removed from the home, but they actually ended up arresting mom because, well, I don't know. I think they should have both technically been arrested. I don't really know how it works, but I guess it's because she's the one who initiated the physical altercation. So now mom is home with the 2 kids. There's like this strange power dynamic going on now because I think there's like some sort of like order of protection where like if, you know, mom even like raises her voice, the son can call the authorities and she'll be arrested again. So right now mom's just like trying to stay away from him and not have any sort of conflict with him. And with the hopes of like that he'll eventually leave or get removed from the home. But yeah, my patient's like stuck in the middle of like helping them communicate with each other, and she's like very much in the middle. So
Has physical aggression been part of the mix over these like many years with this family?
So as far as I understand, no, not in terms of like, not to this extent. I think there's like been some like a lot of like shouting and maybe some like pushing even, but not to this extent. And just between the mom and the brother, this has never involved my patient. Nora or Elena, maybe you guys can chime in. I know that you've known this family longer.
No, I think I certainly don't remember it, other than what you've already referenced, that when like your patient was in middle school, they both had witnessed domestic violence against the mom, but not within the three of them. And I did want to add, and I just know the family well when I used to work with them, but mom has both emotional dysregulation plus her depression, but she also has she just has a very difficult time expressing herself, and sometimes she almost has some, not selective mutism, but she has a lot of expressive challenges. So it's, I don't know if Nora, if you want to add anything, but I think that all her functioning and these particular challenges with the son's, you know, his selective mutism and his anxiety, it's just your patient, Marlene's patient, is really the one that is not just the adult since a child, but she's really a markedly high function in comparison to the other two.
Yeah, just to add, we did, of course, involve ACS. Apparently, Marlene's patient went to school the following day and got a lot of support from the school counselors, but we were not in a position to find out from the school directly if they had called or not. So we did initiate that, and they have been, you know, doing random check-ins. But I think, as we all know, those organizations are very full and busy, and it's sort of hit or miss. So we're not, you know, feeling that we're going to necessarily get too much support from them. Besides sort of, you know, some more eyes on. So we've kind of, our family therapy team decided to take a little bit of a approach to working with them, and our hope is that we can, if they would like to, continue working towards like a repair, and or at least figuring out a way to continue, if their family goal continues to be to get Cleo to college, I'm sorry, to get patient to college, to do that. So we actually met with mom just a couple hours ago, just for an individual session. And our hope is to meet with the son for an individual session next week, and then potentially to meet with mom and daughter together for like a dyadic work session, because at the moment we can't do, because of this sort of restraining order-ish thing that's going on, order of protection situation, we can't actually, it sounds like, have the son and mom in the same room. So man, we're trying to think creatively through this. Would love thoughts or ideas.
From the ultra big picture, you know, the thing that's interesting is it seems like there's like this parallel process with the family's kind of dependence and connection with clinic over all these years, right? With the role the daughter's in, that it's really, it's an amazing sort of thing to think about the strength of those relationships, the family with the clinic, the daughter with the clinic, and how that's all working. But it when we get to these transitions, it feels like it's duct tape and chewing gum. But it sounds like, and thank goodness that all that's been there. But it sounds like what you're saying is both the mom and the brother, probably with many diagnoses going on, brother too, I'm guessing, haven't been able to move forward with progress themselves with communication or emotional regulation. Is that fair to say? That that's really the challenge? And okay. Neha, you were going to say something?
I think I was just deviating a little bit, maybe because I have a similarly 20-some-year-old selectively mute adult, and I think that this is the first other person I have met or heard about at his age with selective mutism. And I think I was just wondering if there was any neuropsych testing, especially since there seems to be some family component here. I mean, I think what we discovered is that there was an underlining like bipolar and psychotic piece to my patient. And that kind of helped a lot. I think the selective mutism persists, but she's been stable. It still didn't help in engagement and communication, especially in a relationship between her and her mother. But there has been some improvement, just kind of fine tuning what's underneath it. But that's not family therapy component. It was just this other piece that was bugged, in my mind.
But it is potentially, if you think about biopsychosocial. So if they have, in this case, it may not be bipolar, but there may be a genuine language disorder. And it's known that people with language disorders are often expressive with behavioral when they're upset. So I'm thinking like, what would that gain you if that diagnosis? Well, it could help people to understand that this is not purely psychiatric, that this is a neurologic difficulty, and that could take off the shame to some degree and maybe lead to other kinds of treatments that can help with the language disorder part, and also just with a reframing that, of that. And would that take the pressure off of the 15-year-old because the other two are now getting help? So I think it is related, actually.
And may give her a little bit of hope that it's not for her to manage per se, that it's not her job to manage them, but there's a team that can be more helpful because they have real issues and they're not trying to make her life difficult either.
Right.
I had a kind of radical thought that popped into my head along the lines of what Michelle was saying, but like maybe more extreme. And it's more of a devil's advocate thought, but I thought, well, if he's not as selectively mute with other people as he is with the clinic because he's been with you guys for so long, and that stubbornness that comes with selective mutism, like I've never spoken to you, so therefore I'm not going to break that habit with you, but like with fresh new people who don't know this about me already, then I'll act normal. So maybe he shouldn't be getting treatment at this clinic anymore. Start fresh with somebody who doesn't already know that about him. And the devil's advocate part is because, obviously, good treatment is few and far between. So that's probably offset by all the, the knowledge you have of this family and all the wonderful things you're doing. But it was just a radical thought that, like, really, when you said that about the parallel process, it kind of makes perfect sense, because the daughter too, like her leaving for college is going to hugely disrupt the homeostasis. However, does not mean that should not happen. And in fact, I think probably the best thing you could do for that family is to make sure that happens, regardless of how it's going to disrupt the homeostasis.
I was thinking the same, Chrissy, and in a way it felt like the clinic became so part of the family system that it was actually important to that system to kind of the clinic to come out of the picture, because it's just too invested and too in it. So yeah, thank you for saying that.
Yeah, so it's
just
like
knowing kids like that. I mean, I call him a kid, but knowing kids like that, my son doesn't have selective mutism, but he's a little bit like that, like the stubbornness. Like if you put him with somebody who's never seen that side of him before, then he'll go into a new mode,
I think it's such a great example of how we're constantly having to toggle between the individuals and the we, right, of the family. And part of what everyone's getting at is this idea that we really need to understand with each person what their needs are, and then figure out, like, especially again, what's treatable, what's not, is part of the issue that, like, as you're saying, like the brother's resistant to maybe services or other things that he needs that he's refusing, right? To kind of reorganize. So it seems like the good news about the transition is it's pushing for that. The other thing that I think this is a good example of is when we think about sort of the family process parts of this, like in a family like this, where there's members who are so dysregulated and struggle so much with basic communication, they can't do what I would call repair loops. Do you know what I mean? That they probably, I'm guessing not, they probably don't have a process when they have conflict or when they're stressed to be able to get through it. Even in clinic, it sounds like it would be hard for them to do it, like even in a family session with help, right? Never mind to then repair after a traumatic incident like this.
Yeah.
But that's where there's some differential between the family members. So I like the idea that you're going to get the mom and the daughter together, because I would hope that at least mom and daughter together with help from the family therapist could do some repair work around how hard this was for both of them, but certainly for the daughter, and that mom could have the opportunity to be a mom in that way.
Yeah, absolutely. I mean, these are just such helpful ideas. I mean, we were also just talking with Marlene specifically about transitioning her care as part of that kind of fresh start, separating from our system. You know, when her patient goes off to college. Yeah, because there is the possibility of remaining in care with Marlene, and yeah, so the question kind of came up, would that be in the best interest, or maybe it should, maybe a new person, like a separation from the clinic might be helpful. But just to answer one of the other pieces that came up, the son is no longer in care. Roughly after he turned 18, he was like, bye, I'm done. And, you know, went off he also had ADHD, so went off his ADHD medication, and, you know, made that choice to no longer engage in therapy as well with his longtime therapist.
Wow.
I think heard his voice maybe once. I heard him giggle and talk to friends once, and we run like a summer program, and I was like blown away because it just would never happen in our clinical context. But yeah,
So
if he were
he's
still in the clinic, I love that idea that he should, you know, potentially be with someone else.
if he's out of care, would it be possible to try to plan for a session with him with mom in the future? And I know there's that protective order right now, but you can go to the court and have the protective order modified to allow for them to be in the same room during visits. You know, they might need to be separate in the waiting room, but you know, if you felt comfortable with that and thought it was safe, then you can get the order modified.
Yeah, no, that's a great idea. I think it would be a good goal for the future. And even though he's not in our care, we bring him into the family sessions, because since 2 out of 3 family members are, we always sort of act with the goal of like, what's going to best help this family, and we don't restrict family work to who is specifically in our clinic. Like one person certainly has to be, but not all the members.
It also, that gets into the issue with, it sounds like mom, for many good reasons, has struggled over many years to set any limits with the son. Is that a fair thing to say? That, because it sounds like as you're describing him diagnostically, so far at least what you're saying is his level of functioning is much more impaired than we would expect with the diagnosis he has. So there may be other things going on, but it also sounds like understandable with a mom who's been this impaired herself with depression, etc., and dealing with trauma recovery.
Yeah. Yes, absolutely.
I wonder what would happen if somebody working with the son said, look, I don't care whether you talk or not, that's fine. I mean, it's more important that you be able to figure out a way to make some money so you can feed yourself, because your mother's not going to live forever. And, you know, this is your choice. You can talk or not talk, but there are plenty of, there are plenty of people who can't talk or don't, you know, because they're deaf. And, you know, maybe we can figure out a way to help you. So what would you like to do? And see if there's, and I'm not suggesting you do that in your clinic. I think the idea of their getting a fresh start can give themselves a different frame of who they are too. But I wonder, what are your thoughts about that kind of idea.
I mean, I think that would be really important for him to hear. It may happen regardless, because mom, at least right now, is saying she wants him out.
Mm,
So he's gonna have to figure things out,
yeah.
you know, whether that means going into
And that
shelter.
gets into a whole other set of legal issues, right? Which are complex.
Yes.
Like it's actually harder for parents to throw a young adult child out of the house than we would think. Even
Yes.
like legally, right?
Yes.
Yeah.
And I think that's her anger. You know, I think there's an anger response right now that's very just prominent. And you know, maybe it's not. Maybe it's her response at the moment of just saying, yes, I want him out, I want him out, is just coming from a really angry space, but not necessarily
And
thinking.
it's also a little, you know, maybe helping redirect her not to say that out loud until she actually knows that there could be a real plan of where to send him, because otherwise it's an empty threat, and that kind of perpetuates this whole cycle of her not being effective in her enforcing anything with him. But I was curious what if there are any extended family members or anybody, like any place that's been floated for, like, other than just generally getting out, is there actually like a friend or anyone he could go with?
We were talking about that. He appears connected, although he doesn't tell mom much about it, but he appears connected to his church group. And
Ooh,
seems
that's
to have,
helpful.
seems to have friendships there, connects well with the pastor there. So that might be a realistic potential option, that they may know of some housing.
Yeah,
it's-
I mean, maybe they even know maybe there's a member of the church who could put him up for a week or two just to even give them some space
Right.
and breathing room, even if it wasn't a long-term solution.
Right. And connect him with another therapist who might say something like, I don't care if you talk to me, let's figure out how you can get a job.
Mhm.
And there really is again a parallel process between the clinic relationships and the family ones with setting limits, right? It's really interesting. And I often think in these cases, it's very hard in many ways to do operationally, but it could be really effective. Doing like a large network meeting at a transition in a family case like this, right? That's this complicated, can be really helpful. Meaning everyone working with anyone in the family coming together and saying, what do we actually recommend here?
Hmm.
Right?
Do it in the church.
What does the brother
Well-
need? What does the daughter need? What does the mom need? What can happen in clinic, what not? And then work as a team to present it to the family in a network way. And I don't mean to make it more complicated. I actually mean to distill it down to these most important things. Like I imagine this mom is aware that it's been really hard for her to set limits on her son. She
Oh,
probably
yeah.
feels horrible about it. There's many good reasons for it. Does that make sense? But so again, network meetings can be really helpful.
And I agree with Tom about about including the church and some, the person in the church. That's-
Or having this family meeting in the church basement.
So we do see this family virtually, and I believe the two, mom and daughter, and I may be wrong, Marlene, but since pre-pandemic, they have not come into the clinic. So
They probably
we've
could.
been able to, and this,
Doesn't mean they can't.
I'm sorry, Nora?
I'm just saying, like many of our families, they probably could. I have to remind a lot of people, hey, before COVID, you guys were coming in. We can make this work. You know,
Right.
I think they're just, people are set in the new routine, but that doesn't mean that can't happen.
The subway still runs.
Yes.
I'm gonna have to leave, everybody. This has been great. Thanks for having me involved, and I'll see you next time.
Bye, great to see you.
I don't know if people are interested or if it's helpful to get into this level of detail or not, but would it be helpful to brainstorm a little bit about how you would construct a session like with mom and daughter? Or how you would then to get at these things and how you would do it with mom, daughter, and son? Related to the safety issues or not? Like we don't have to do that.
I think it would be helpful to hear what some people in here think about that. I would, I think before that, it might be helpful to hear a little bit more from Marlene. Is it Marlene or Marlena?
Marlene,
Huh?
it's Marlene.
Marlene, about like what are the goals for the daughter right now? Because we all, I think the parallel process happened again, right? We all stopped talking about her, even though she's the patient that was sort of first presented in the family when Marlene was describing the case. And so it's really easy for her to get left behind when there's so much chaos going on with the other two. But she also seems, it's also kind of a parallel process to what we were talking about in terms of like, who could get the most benefit from a service, right? Like clearly she's the one that is like at the cusp of this transition where it's like make or break for her. And, you know, I hate to say, but the other two are probably a lot more stuck and difficult to treat. So, you know, maybe let's put our eggs in the right basket. And I hate to move away from like a typical kind of overarching family way of thinking about this, but I kind of like am pulled to moving towards like what is best for this one person in the family right now. Like who does she need to be in the room? What are the goals and the pitfalls for her? And yeah.
Well,
Yeah.
also, would she buy into the goal of no matter what, you need to go to college? Because she may not. And how to
I don't
help.
even know. Yeah, I just threw that out there, but I don't even know all the factors that go into that decision.
Yeah, no, I think that is the goal. The goal is to get her to go to college, right? She's worked so hard, like insanely hard, right? Like I said, she's like valedictorian, did like all these like activities and work and all these things, and she deserves to go to college. She worked really, really hard.
Is there
And
somebody who doesn't want her to, or like an obstacle,
so
like any remaining obstacles, I guess, to
I think
that?
it's more like emotional, like feeling responsible for her family, and her family's functioning. Mom is like very adamantly saying, no, I want her to go to college. But just today, right, like the family therapist got her to like acknowledge, like, okay, there's a large part of me that doesn't want her to go. Emotionally, like I don't want
And
her to go.
that's what they need to talk about together, because they both
Exactly.
share mixed emotions about it. That's the session, right?
Exactly. So I think that's like the hope to kind of talk more about that in like the dyadic section with session with both of them, to kind of get access more of that. Because right now it's like, no, yeah, like, you know, I want her to go to college, like 100%, right? And there's like a lot of you know, there's no acknowledgement of the fact that like, yeah, this is going to be really, really hard for mom. Really
She's your
hard.
individual. She's your individual client.
Daughter is my individual
Yeah.
client.
I mean, again, I'm like, I feel like I'm in this weird, like, you know, leaning away from my normal kind of family therapy hat, I guess. But I feel like, maybe the individual work is like really important. Not that it needs to be the only thing, but like, maybe that's really important for her right now because her interests need to be put first, you know, and that that might be really hard to do if those other people are in the room every session.
Yeah.
So is the family
Combination but good, Betsy.
I just wanted to understand the family therapist is not one of us, not one of you?
No, no.
That's it. I see.
So how we kind of structure it at our clinic is that we kind of do like this behind the mirror, where the rest of the seminar is watching the session while the family therapist is obviously doing family therapy. So we're aware of what's going on because we're observing, but yeah, we're not the actual the ones doing family therapy.
So what is the therapist doing and what has he or she done? I mean, what does that piece of this puzzle look like? Because she or he has given a frame to the family by the way that he or she is working with them. So I don't know how you guys can do anything without that piece of the puzzle being included. Not here necessarily, but also for our thinking and helping. What is that person doing?
it sounds like been helping them survive.
Well,
basically,
yeah,
right?
yeah.
Like crisis to crisis. Yeah.
Yeah,
Well,
I
I
think
think that, yeah, I mean, I think that if you know, Marlena, if you can know as much as possible about exactly what's happening in those sessions, that'll help you help her better, because you're going to be like her protector, you know, like if she's getting caught into like helping others too much in those sessions, then you can help her kind of reflect on that and, you know, and help her sort of put herself first, really.
I actually think, Chrissy, that I don't think you are really swaying from a family systems issue, because the way I look at it, we're so often helping families, whether we're meeting with someone individually or with members of their family, dealing with that I-we tension.
Yeah.
You know what I mean? Like, I think about it a lot in couples therapy. This comes up that I'm always normalizing for couples. Sometimes a couple makes a decision for one person, sometimes for the other's needs, sometimes for the couple's needs, right? And that it's a constant balance. And I did talk that conversation with families as well.
Yeah.
And I agree, you're totally right that this kid needs that protection from Marlene to make sure she's not going to get pulled in, right? But I want to believe in mom a little bit, that mom's going to be able to encourage her daughter to go on this healthy path too, with help.
Yeah.
I wonder if there's ever a time when it would be useful for a co-therapeutic session with you and the co-therapist to discuss this, but to support that, the daughter's responsibility is to grow up and be competent, and that's what every mother wants.
Mhm.
And I worry a little bit about, like whether people are working at cross purposes, unintentionally.
Well, I do have to say, so the family therapist in this case, he heads up the family therapy with along with Nora in terms of at Columbia, and so he's extremely he's just a wonderful therapist, and he's very experienced, and so I think, and the great thing about our team, behind the mirror, is that so everyone is aware of, what he's doing. He also comes back,
Oh, good, that's great.
at the end, we
Like
gives
that.
us 10 minutes so the family knows that the team gives him feedback, and then he goes back with the final message. I personally wish that the mom's therapists were part of this, because that's where I do feel like a big
Oh,
hole and a real absence. And some of us just know the mom well throughout the years.
Oh,
But
yeah, I
I
didn't
do
realize.
think, and I think that, Scott, who is the family therapist, he's doing a phenomenal job to try to get to, again, these underlying emotional issues, to do just that, to help mom kind of let your kid launch.
So does the mom have a therapist somewhere else?
Yes,
Or
no, in our clinic, and has.
oh, in the clinic, but so that person's in communication with you guys then, or no?
Yes, but it's
Oh,
very,
Mom.
there's I don't feel that there's tons of information or that's shared, but I do, to Chrissy's point, and Marlene is kind of spearheading this, but we all feel it on the family team. Our goal, primary goal, there's just so many goals. It's to get this kiddo out of the house, away to school, and that would be like a major success, I think, before her case gets closed.
Yeah.
The son's case is already closed. The mom will be there for another 20 years.
Is she going out of state, so you can't see her anymore when she leaves?
So it's actually not. So our clinic is structured in So our clinic has a grant and the mom is grant funded, but the kids are not. So once you age out, like 18, right, we're technically supposed to transition you to an adult clinic, but if you're a grant funded patient, you can stay for as long as you'd like. So mom's grant funded so she can stay as long as she'd like. Daughter is not, so we have to transition her.
And there's flexibility, but for all the reasons that were discussed, you know, it just, perhaps it really does make a lot of sense once she's in school that she get, you know, she gets support there, a community therapist, you know, especially with telehealth.
She needs a fresh start.
She needs and I know this sounds maybe terrible, but I really feel like our clinic, we've done great work and it's been very, there's rewards and it's also been very frustrating. And I kind of feel like we are stuck in terms of the work with mom, with the son who's now no longer with his individual therapist. And so, yes, so I think everyone's goal is to get this girl who's graduating in a few weeks off to college.
It's so fascinating because I think we all agree with that sentiment, of course, but it's fascinating because it's like it's obviously not our decision. Do you know what like really what's going to happen? I'm not saying I don't hope it happens, and I want to support them getting there, but I just think it's fascinating that essentially it's become this, we've got to protect this healthiest person in the family. Is that interesting? Like, I don't think we normally react that way, right?
I hear this story and I feel like it's just the three of them at home. There's nobody else, right? Yeah. So like, what if she goes off to college and something really terrible happens and her brother hurts her mom seriously? You know, that would be a terrible outcome. Like, I think she's going to have to feel safe that they are going to be safe if she leaves, or it's not going to work.
Or not. She may have to be helped to realize that she cannot make the difference and take care of.
But it's not her responsibility, and that there is you can't live based on, you know, a
you
risk.
can't ignore a third person living in the house. I mean, it may not be her personal responsibility to control their behaviors, but she could be a buffer there, you know. And if she's not going to be the buffer,
she wasn't last
something
week
else
with it,
has to function
right?
as the buffer or the communication method. You know, something needs to fill the space. It can't just be empty.
Well, I think that the incident last week is a perfect example of how that's not working, though. You know,
Yeah.
And you never
she was
know
in the
what-
house. She was in the house when that happened.
Yeah, and maybe that would make a difference if she's not there, in the sense of, boy, we better not get too hot here because we don't have.
She won't be able to fix it. Yeah.
And I'm still fixated on the mother's therapist, and I this may be my not taking it all in, but is she really on board with helping the mother to really truly help her daughter launch?
So, the mother's therapist isn't really involved in these discussions as often because he's not part of the family therapy seminar. So the reason we get to talk about this so much amongst us clinicians is because we debrief every week, talk about the cases, right? So I give updates every week about what I'm working with my patient. It's my understanding that the mother's therapist is taking on more of like a DBT lens to help mom with emotion regulation. So I don't know like how often they're talking maybe more about like mom's other feelings about like the daughter leaving, aside from like mom saying yes.
Or her parental functioning, right? I would be hard pressed if I were the family therapist to be able to go in the room productively with mom and daughter right now, if I didn't have some side conversation as the family therapist with mom and do kind of a taking stock with her about what she's understanding about all this.
Yeah, that would be appropriate. That wouldn't be, I don't think that would be stepping on the DBT toes.
No, and I would certainly be in touch with the therapist, but those would be the questions I'd be asking the therapist. Like, one of the most interesting questions for the overall clinic trajectory is, has mom moved at all in terms of her beliefs and her understanding about how she can parent the kids in a healthy way, being as overwhelmed as she is? And I don't know the answer to it. It may be hard for any of us to answer that, but that would be important to know, I think.
I think that makes, Michelle, that's such a great question, and maybe that's something that our family therapy team can talk a little bit more. Like, I know the DBT consult team, they bring in therapists who are seeing perhaps a patient who's in the DBT skills group, but are not in individual DBT therapy. So we're, you know, we collaborate a lot. We're a small clinic. But, you know, and I haven't worked with the mom closely in several years, but I can say that, I mean, this family probably has gotten more services than I think any other family I can think of. I mean, they started with PCIT for several years, you know, individual therapy. She's been mom, you know, some DBT skills group, individual therapy, you know, summer program, which is more of a socialization for the two kids, like, and now family therapy for several years now. So I don't know many clinics who would put.
Well, I think it's interesting. Like, it's such a complex question with our delivery of care,
Yeah.
and I think fascinating, right? Like, I believe in, and one of the issues with clinics sometimes is that providers change,
Mhm.
you know, and that can lose the view. Like, are we getting anywhere? And I'm not saying this in any way to vilify mom, but just being realistic.
Yeah.
Like, if family therapy really hasn't moved her forward in that way, then maybe even over time, like, goals should shift. And as we're saying, like, the young woman needs to be looked at in a more independent way, maybe building other supports in her life. And
Yeah.
how does she build boundaries with her mom? Or do you know what I'm saying? Like, sometimes we lose that long view of, like,
Yeah.
we're not going to just keep doing the same thing.
And yeah. I
Yeah,
mean,
It's a fascinating question. And I do think there's families, and some patients I have and families I have relationships with, that they've needed to remain dependent on me at some level for the really hard stuff. You know, that they've been able to make progress over the years, but there's certain things that they're just not going to be able to do without the help of treatment, which I also think is okay, as long as everyone can move forward in whatever way they are trying to. Does that make sense? It's a fascinating question.
yeah, and mom will stay at the clinic because since she's grant
Yeah.
funded, so she has that support. I mean, I have my own opinions of her capacity. Truly, there are some, I think, limitations there on different levels. You know, and I'm not saying she hasn't grown, but I think she struggles with a lot of the same kind of diffuse boundaries between her and her daughter, and really seeing the daughter as an extension of herself. And I know this sounds a little bit more psychodynamic, but yeah, I just worry that she really, in this 3-month period, which is, and we've all talked about that. It's like we're all feeling like we're on, you know, on coals, like just on a minefield. Like, what is going to happen? And this didn't surprise me that something like this happened. And I wouldn't be surprised if there's other incidences this summer. So I find it helpful to have these kind of questions put out there, and maybe for the team to really think about in terms of focus and reframing things, especially if her services will be shifted or transitioned to, you know.
I mean,
to
that's such a
care.
brilliant point that probably some layer of this last week is already the, you know, earthquake coming.
Yeah.
Right. The other thing I love about the fact that you guys shared this case is how much it highlights kind of the well sibling issues, which are so often, like, neglected. I actually have a wonderful paper. It's actually called The Well Sibling, written many years ago. But Marlene, it might be especially helpful for you to frame normalizing some of this for the young woman. But I'm glad to share that with the group because there's such powerful dynamics.
Mhm.
Can
Yeah,
you
well,
share
and
more about like what you mean by that?
Meaning, like, for this, as you've described, the young woman is the highest functioning in the family. Sounds like probably always has been. has been parentified, etc. Right? And there's so many, it's such a complex thing. And I'm not saying that that just affects people in negative ways. There could be positive that comes of it, right? She'll probably be a family therapist one day, right? But there also can be a lot of destruction and negativity, right? And it's normal that sometimes siblings have their own issues going on. Like, it's great she's been identified and is in treatment, but a lot of times they're off to the side and maybe they're depressed and have other things going on that their parents don't even have the energy to attend to. Does that make sense? I have a case that I just got involved with recently that I won't get into all the details, but there's 2 daughters in the family, and the younger of the 2 daughters has had very severe anxiety for several years, to a point that she literally holds people in the family hostage with yelling and screaming fights. And her sister, her older sister, has gone through depression herself over the years, is now doing well, now in college. But I got involved to do family therapy, right, in this minefield where the parents are literally terrified of the younger daughter who's in high school. And so as I entered, I talked with parents, and then I had separate conversation with older sister, with younger sister. I'm trying to do the different pieces, but it was so profoundly sad talking to the older daughter about how for years and years, like, she hasn't spent one-on-one time with her mother in like 3 years. Because her now 17-year-old sister can't tolerate it if they're both home. I mean, these are the patterns that happen. And again, and now, like, we're working on it, we're talking about it. And the parents know, like, they've accommodated the younger kids' anxiety all this time, and they're trying to get out of that. Does that, you see what I'm getting at? So it's just really powerful forces that can really affect people a lot.
Yeah.
Chrissy, I think you were involved when we did one of the sibling things at ACAP a number of years ago. Yeah, it's such an important topic.
Yeah.
Well, and I remember, Michelle, you always taught us the question about taking things to the extreme and asking the family, you know, what if you know, how bad do things have to get for her to come home from college? You know, what are you guys going to act up when she leaves to make sure that she returns home, or something, you know, something along those lines?
Or you're talking about Tom's perfect question.
Yes, sorry.
That what you're talking about is a question where if the symptoms were to increase, how does it change a relationship in the family? Yeah. But what were you going to say about that with this family? It's a good point.
It would be good to just put that out there on the table and see what, you know, they're probably all wondering. And but if they're not actually talking about it with each other, you know, I'm sure the daughter, you know, probably feels some sense of responsibility, being the well one, that if she leaves, you know, should she be doing something? You know, the mom knows that she's responsible, but also has this like doubt about whether she can send her daughter off. You know, probably for good reasons, because obviously her son can pick her up and throw her on the floor. So that's not necessarily a safe situation. You know, maybe the brother can't live at home if the daughter's going to go off to college. Maybe that just can't happen, having the mom and the brother
Maybe he'll get hospitalized or go to residential or something, which is maybe something that could have happened earlier if she had already gone off to college, you know?
Yeah.
I'm hopeful about the connection with the church, and that possibly that could be a connection with the young man, and maybe even broader for everybody.
Yeah.
As a support and encouragement, and it's another context of safety and caring.
But even within our own family therapy team, like, I like this idea, and I can see the benefit of posing that question. Because mom is also having surgery this summer.
Oh, wow.
Which she's gonna have to have homemakers be in the home. So that is just another big disruption. And
you know, I'm sure you guys did this, but really like praising her for calling the police when that happened, because there are so many families like this where they just do everything possible to avoid calling the police, and then the young person doesn't, unfortunately, she's the one that then
She got
experienced
arrested. Yeah.
the consequences and not him. But yeah, figuring out how to like not let that stop her from doing it again next time, because he does have to experience some natural consequences, right?
Yeah, I was thinking about that too, just because he's also a Black male, right? And so I imagine that was a really hard decision for mom to make.
Yeah.
But I agree, right? It's at the end of the day, like everyone needs to be safe, and what was going on was certainly not safe.
I know this is a kind of a dumb thing to say, just another point, but sometimes when people are leaving the home, like to move to college or whatever it is, we forget the reality that they're still going to be very present wherever they are and being an emotional support, right, to the rest of the family. And I just think that's going to be really helpful to have them talk about, because sometimes families experience it as it's all or nothing. But I'm always talking to kids going off to college about, with their parents, about what's everyone expecting is when you're going to call and text. And do you know what I'm saying? Like what that's going to be like? And that may get into the daughter's worries about mom calling and saying like he's attacking me or something, but then we could talk about it. Again, I know that's kind of a dumb point, but it's really true. Like they're together forever, these people, wherever they're living.
It's not a dumb point. That's a really important.
I completely agree. And in some ways, right, maybe that would ease mom's like anxiety about the daughter leaving as well, right? Knowing that someone else was putting it this way, but just knowing that like her and mom will always be connected, right? That's always going to be her mom.
Mom's going with her and the daughter's staying with mom, even when they split. Like that's the way it works. And that can really help people to talk about it, because people experience it more extreme than it is.
Well, and if mom sees the daughter as an extension of herself, and it's like the highest functioning part of herself, and she feels like the best part of herself is going away, that would be scary.
I think this is a growth edge for mom. I totally agree. And it could motivate her to get to another level with what she needs to do for her own needs to be met, her own needs separate from her son's as well.
I also wonder about the brother. Like, what are his thoughts about his sister leaving?
I mean, he just says like, yeah, it's great, right? Like everyone says it's great. No one's like actually speaking about like the underlying feelings around it. Just like, I imagine it's really scary to lose the family member who's bringing in money to the house, right? Let alone functioning the highest in a lot of other ways.
Right.
I imagine that's terrifying. And so everyone's, I think, trying to be like supportive of her and all of that, and everyone's saying the right things. Right. We know that underneath that, there's a lot of other things going on, and I think they're playing out in these other ways.
Yeah.
Sometimes the most therapeutic things happen at the wrap up of a long family relationship with a clinic like this, right? Like that, I think it's really true. It's such an opportunity.
Yeah.
So don't hold back, you guys.
I even today, the family therapist was really, and he has such a gentle way about him. It's so when he says I was being more directive than I usually am, and I was like, yes, like really helping her. And she was able, mom was able to identify this sadness.
If you open the door for her, she'll do it. And
Yeah.
I look at it like sometimes it's more about being active than directive. Does that make sense? Like I'm not going to tell people what to do, but to be active and say, okay, what's the best and the worst about this? What's the most joyful and like always, both sides.
And this is with Marlene's patient, the exception, but the son and mom are really concrete thinkers. So I even appreciate just these questions to, how will you? I mean, I remember when I went to college, every Sunday I had to get on the payphone, cell phones, and I would talk to my parents. And that was the expectation. And in my close-knit family, but
I remember writing letters.
oh my,
So
I'm
easy
still
now.
friends with my friends in England when I
Yeah.
left at 12, and their kids are like, you guys were pen pals? But yes, I think the more concrete, helping them just even envision, how are you going to stay in touch? So it's not
Yeah.
overwhelming for any of them, but
I also wonder concrete thinkers who already have expressive communication problems, would working on other de-escalation methods be helpful for all of them? So like DBT is great for helping mom understand herself and the world around her and stuff, but if she loses all her words when she's really upset, she's not accessing her
Called
DBT
take
skills
space.
at that time.
Take
Yeah.
space.
But they could have something like, if I go pick up the red ball and I'm holding the ball, then I'm very upset and you should not talk to me. And, it's visual, so nobody has to say any words. And they could both understand that that's what that means and just give it some cool off
So
time and
the-
reconvene.
The most important lessons in family therapy around safety are always about helping people know when not to talk.
Yeah.
It's really
You need-
true.
You need more than one ball, though.
Yeah.
Yes, everyone should have their own ball.
We got to know when not to talk.
And then
guys,
when you put
thank
the
you.
ball down again, then you're ready to talk,
Yeah.
or would be open to it, but the other person has to put down their ball too. Yeah.
Thank you guys so much for again
thank you all.
sharing and setting the tone for this great discussion. Thanks everybody.
And thank you, Marlene, for presenting.
Yeah,
thank
that
you
was
all.
awesome,
This was
Marlene.
really
Thanks.
helpful.
Thank you.
Great. Take
Okay.
care.